Really appreciate the opportunity to see who's in the crowd, who we're talking to, but I think we've got a pretty good mix of payers, at least provider representation. I am Matt Cunningham, in charge of our end-to-end authorization solution. So that includes our AI platform that we acquired in April of last year, and working with the Florida Blue team in the state of Florida to automate the prior authorization process. I'm not going to talk specifically on the AI piece of it. However, the booth right next to us right there can give you a demo, work through it. What I'm going to spend a little bit of time talking about is the concept of authorizations being a use case, a very good use case to promote interoperability across the industry. When I talk authorizations, I'm not suggesting that everyone here is an expert in authorizations. So I'm going to give a little bit of a background on why this is such a problem in the industry and what the industry is doing about it and where Availity fits. But I think the Da Vinci team would agree. It's probably one of the most single most hated processes in healthcare, and yet there's this crazy balance that has to happen given our industry. So there was an AMA study in 2017 that asked 1,000 physicians on perspective of overutilization in healthcare. So what percentage of utilization or service performed do the physicians believe are unnecessary care? 20% of the respondents said 20% of utilization out there is inappropriate. So that's kind of the payer's responsibility. How do we manage the cost trend out there? And so prior authorization has obviously been in place for a while. If you ask the same physicians, what's the impact of prior authorization? 93% said that it had meaningfully reduced necessary care, and 35% said it actually led to serious adverse events. So that's the sort of position that we're taking in the market, is how do we solve this problem, but not also diminish the impact that it has as a solution. So this is an education session. We're going to talk business case. I'm not going to tell you how to do a business case, but really just propose the need for interoperability to choose a couple of use cases out there that are the industry consensus use cases in order to spur other connectivity solutions in the market. So why am I standing up here talking to you guys? I usually say that I'm one of the top 10 people in the country that created the problem that we're solving. So you can sort of dart behind this. So I started after a brief stint in the military, started at CareCorps National. So I was employee 20 for the CareCorps team. In 2005, if you knew much about utilization management, is when the industry was moving towards distributed networks. And so the payers had this problem of saying, how do I enforce medical policy, but do that in a way that is not with the physicians being employees? So prior authorization, which is a subset of utilization management, really took off in 2005. So there was probably about 5 to 10% of procedures in 2005 required prior authorization. Fast forward 2015, 70 to 80% of all outpatient services require prior authorization. So there is this huge movement to sort of manage costs, and we created a machine. All right, so I'll tell you a little bit sort of why that's challenging and so solving this problem of automation. But safe to say, it has had its heyday. Majority of the cases out there do require some level of utilization management, and yet impact the providers are significant enough to say we got to do something differently around it. So again, that's me. We came over, Availity acquired an AI solution from Olive that specifically focused on authorizations. And so my team now runs end-to-end authorizations across the board. Availity is the network of network. We were founded by payers to ask the question, how do we get and solve this administrative interaction between the payers and providers? And so we're nicely positioned as a convener for solutions. That's our business model. The size and scale that Availity has gives us a nice platform on an authorization solution to promote these sort of industry consensus changes. So why authorizations? I'm going to talk two sort of areas. One, the amount of point solutions. If you walk through, and I actually haven't seen as many as I expected here, specifically authorization solutions, but since really 2012, we've seen a significant investment in solutions that tend to automate the process. We also have had standards that are now meaningfully working their way through the process. We'll talk about that as part of that, and the work that the Da Vinci project has done has meaningfully moved that forward. So these are the two areas of the industry that are trending in prior authorization, and I'll talk the first one some length. So 2012, majority of the payers in the market were saying, can I do prior authorization through clinical decision support? So instead of doing a ask for permission, can we influence the physician at the point of care meaningfully enough to not have to do prior authorization? I think if you see the studies that have come out since then, most would say that CDS has not necessarily demonstrated impact and had significantly improved burnout. So that was kind of the first attempt to do interoperability with prior authorization. It then started to go into regression models. At the eviCore side, I know all of the other delegated models made significant investments between 2014 and 2017 in things like natural language processing, regression models being the primary purpose to it. So can I predict the likely decision I would make in the future using previous data? And I would say majority of the solutions out there today focus on regression models at some level in order to sort of predict the utilization piece of it. So that happened significantly sort of 2016 to 2018. You then started to see investments in provider extraction systems. So Rhyme, Prior Auth Now, Recondo, a lot of the systems out there that says, hey, I'm going to help a provider get data out of the EMR and send it into these payers, had a significant investment. And I think that the challenge with that solution is they have to sort of connect to everyone in order to get a meaningful improvement to that particular provider. So you have sort of these investments out there in the provider side, and yet when you look at the books for the CFO, they're not seeing any meaningful reduction in costs. And then lastly, rev cycle management solutions, Availity has one as well, would say, hey, if I'm doing claims, correct coding, I should be able to also go upstream, do authorization. So that's what I would say that the industry scan between 2012 and 2023. Very challenging to solve this problem. So, if you look at meaningful use and other types of, initiatives out there, there are solutions out there that get meaningfully solved by standards, baseline standards. So you're generally not going to be submitting a paper for a claim as much as you used to. We have a portal, but for the most part, those are digitized. Eligibility and benefits are digitized. Why haven't authorizations meaningfully been reduced as a result of standards, even though 278s have been out there since meaningful use? When I started in 2005, it was nurses on a payer side talking to nurses on a provider side about a medical policy question, talking about how that medical policy applies to the course of treatment. And that actually worked really well. It was good, rich, necessary conversations, and especially at the 20 to 25% inappropriate utilization, it was important. It didn't scale. So what happened after 2005 is we started to do these attestations. So building out the medical policies through sort of a question and answer sequence. And we posted that on a website for the most part in order to get the provider systems to go and manually operate majority of what the payers were sort of doing over the phone call. And that worked, at least by scale. That's one of the reasons why we scaled so quickly is because I could accurately have a provider system go through an attestation tree, right? The problem with that is you've got non-clinical people, sometimes with access to clinical information, generally not, talking to a machine that is an attestation to get an output. So if you look at the current state, it's non-clinical people talking to machine compared to clinical people talking to clinicians, right? So that's the, again, necessary state. But this is one of those areas in medicine where it needs to be messy conversations. The reason why we're talking about the 20% is because they're the hard questions, right? So that's the first part. It's significantly burdensome 100% of the time. Those cases that we went on the website to build a case still have to copy and paste that member ID on the web portal. So while web portals do improve some of the provider costs, it hasn't materially improved the payer side. What is the clinical data necessary? Like if I were to ask a question, give me information related to MRI of the head, what specific information was collected? That's kind of variable with 350 to 400 CPT codes managed on a particular scenario. So this idea that there's variability in the process. The turnaround time is somewhat, 4 to 10 days across the board. If you look at that number, even if you get, an escalation opportunity for urgency, you could argue that is an impediment, at least a stopgap to care. What is the medical policy? I know the Florida team writes their own medical policy as part of an internally managed group. MCG and Interqual are both licensed medical policy. All of the internal vendors or the delegated vendors write their own policy. So if you were to ask as a physician, how do I qualify and meet the standard for that medical policy? It depends. Even though the underlying clinical science is generally the same, you're going to see very little variation between things like brain cancer and use of that for surveillance scan after a after the patient's in remission, as an example. So the problem is we have all of these things under a firewall, and a lot of those things are proprietary in nature. It lends itself towards some challenges. And lastly, I think there's this general statement that there's a black box out there. Having worked on the payer side of the equation, I don't know what one nurse or physician who's doing anything other than what they're asked to do at the highest license. And yet the provider side would argue it's a black box that is trying to deny my care. Like, there isn't another industry out there where there's that much animosity and lack of trust between the system, right? So there's the problem. Like, you get all these, I have a standard of 278. I've had that standard, for a long time. Why aren't we reducing cost? It's these challenges. This is not an easy problem to have. So what we're faced with in 2023 is the two major problems to solve are, is it require prior authorization? So that question. And then secondly, is it medically necessary? But I think we have some, consensus. If it has all those stakeholders out there, like, what would be the goal that would be, if done, it's success. Like, we can see this meaningfully change. And I'm not talking even, bottom line costs to the providers or the payers, but that translates to it. So the first of all is just make it less manual. It's crazy in 2023 that the structured data that goes through the system is as manual as it is. And 90+%, I'll say, advanced imaging of the decisions are yes. So they're relatively straightforward yeses that take a whole lot of work to get to. Not to say that those 80 to those 10 to 20% aren't necessary, but let's focus on those compared to the remaining 80% of it. So I think there's this consensus. If I have to do it, let's reduce the significant burden to it. Cost, anywhere between $50 and $80 per transaction, depending on which side of the cost is in given volume. Cleveland Clinic, I think, has somewhere between $12 and $15 million just in administrative staff. And I know for a fact the payers are in this equal side of it. So there's significant cost across the board that you could argue is not necessarily going towards the care delivery in their MLR. Let's make it more observable. Why is it that the rules are so behind a firewall? If I'm going to make a process, how do I make sure that is transparent and observable in that statement? I think, again, this sort of black box nature. The idea that this is sort of one group to solve the problem, I think there's an opportunity to significantly create a consensus around industry partners that can move together to meaningfully improve this. And then lastly, let's make this touchless. For the most part, let's make this a process that you shouldn't have to do. So that's utopia for majority of the industry consensus. I don't think there's a payer provider who wouldn't look at that board and say, let's go do that, right, as a concept. So the current state's not so encouraging, right? So if you look at fully electronic, and that's 278, and I would argue that's going to be more of your transactional cases that are going to be fully electronic, where you can do a rule set or a pharmacy benefit, where it's going to be relatively one question up and down. That's at that 31%. Majority of 278 transactions out there are status checks. So is it done yet? Is it done yet? Is it done yet? Very little of it is case creation. So that's a little bit, misleading. And this is CAQH does great index each year around sort of the trends. Partially electronic web portals, and that's down. So Availity is a multi-payer portal. We argue that at least at a minimum, you should go to one place to submit your authorization compared to others. And it has significantly improved the payer's cost. So if I create a case instead of faxing in a case, if I call in a case, all of that is work as an intake agent on the payer side. If you put a portal, a lot of that burden goes away. So there is benefit to there. It does speed up the time for turnaround because of that. But we're down 7% from 2022. We're going the wrong direction. What's going up is the mail, email, fax channels. And in some cases, it's because if I would create a case and that case gets initiated, and then I have to also then fax a clinical document, why don't I just fax the entire thing, right? So until the end-to-end process is solved, we're going to see these more manual channels continue to operate meaningfully. So what's great about that is there's hope. In and I'll talk standards in a second, but in 2021, when we spent a lot of time with our Cupid team at Evicor acquiring NLP, but in reality, 2021 AI changed. No longer do you have to do regression models in order to answer the question, is it medically necessary? Can definitely talk you through that across the board, but our CTO, who I usually like to give us pedigree, invented Google Maps and then solved Elon Musk's rocket landing problem, and then has done prior authorization and said it's harder than both of those combined. But AI can now look at clinical information faster than humans can. It can be trained to understand medical policy. It can make decisions related to the individual case when information is presented to it. So that is like the 2005, a nurse talking to a piece of clinical documents. If we can do that on that 70%, that actually is a meaningfully improvement in the potential. So that's the good news. And secondly, there's actually pretty significant push towards interoperability, right? We haven't had this at this rate. And again, meaningful use had some improvements, but in reality, this concept of all these complexities in prior authorization, I think meaningfully is changing. And that came from an industry consortium, not just a standards out there. So the Da Vinci project, which came out of the Wheaties working group, the FIRE initiative, which then joined in that one, I think has meaningfully created a standard by which we can all invest into. There are, and if we made those standards and made them available, you might populate them, right? So there's the challenge that we have. Is just because you have a standard doesn't necessarily mean it's going to be used, but at least it sort of says this is the platform you can use. Two other interesting standards that came out that are applicable to this. There is a clinical criteria and utilization management standard that came out last year. In that standard, it changes the it forces payers to make the medical policy available and transparent. So no longer can you, for government services, put your medical policy behind a firewall. Whether that medical policy is your licensed or not, it actually puts it out there. That's one change. Second thing, and I'm interesting if you guys walk around and look at other vendors, it requires that regression models are not used for the decision. I can't make a recommendation for a yes or a no based on a regression model. So if you look at all of the industry solutions out there that are essentially said, I've got this information, you can't use that anymore. So to date, that changes, and not to say you have to anymore. AI is able to start correct information, but it should be done based on individual merits of that case, based on the clinical information provided, compared to historically patients like you who have this decision generally get approved. Very different decision on that process. So as we're looking at interoperability, those standards are going to challenge the industry in order to move forward some of the current advancements that are out there. This is not rocket science. Interoperability exists, standards exist. If you come tomorrow at 9:30, we've got our Availity team working with the RIME team, along with Baptist Health, talking about the end-to-end solution. When you have an AI solution, meaningful API connectivity and partnership, it's significantly better. Like 80% of the time, you don't have to touch a case. When you have clinical information, it meaningfully improves the decision accuracy and the turnaround time. So I'm pitching that the benefits of privatization are important, but it's real right now. The question is, how do we push scale? So the first one is you can meaningfully reduce burden. That time to care delivery, utopia for me is, instead of today, the patient comes through the doctor's office, needs an MRI. I've had 2 ACL tears. So if I blow my knee out again, kite surfing, I'm going to go to the doctor and he's going to say, you need an MRI. No problem, right? Except the answer is then going to be something to the effect of, and I'll tell you when it gets approved or not approved so we can go schedule a procedure. And I go home, go to physical therapy, do whatever, and it's a delay in care. In the Florida market, for 70% of the time, you're able to say, can you just hold on for a second? Can you go sit out in the waiting room? I'm going to get your authorization, comes back in 90 seconds, and let's schedule your care. So that time to care delivery focuses patient care, not just let's prevent that sort of fractured process. And then quality of submissions. I mentioned earlier that most of the time we're talking non-clinical to machines. Pretty easy to submit the same information all the time. So we're collecting a lot of data related to user submission and how often that is an accurate submission compared to not. And the bottom line is, if you submit clinical documents, it significantly increases the quality of the document. So more data acquisition is the answer to quality, and as long as that doesn't take too long to do it. So those are the 3 areas that we generally would focus on. Again, the challenge is it's hard to scale that. Clinical data acquisition is difficult, and point solutions, and I've got some of our vendor partners here, adoption as a point solution is hard. So if we were to go 70, 80, 90% of transactions are EDI or API compared to portal, ask me in 10 years with point solutions whether or not we're going to be talking about that same 30%. So the concept that point solutions are going to sort of buy a RIME or buy a Humata or buy an Availity auth cycle management solution, in my opinion, is just not going to be necessarily the way we scale it. Secondly, it doesn't count for all the variations in the medical policy or the health plans component. So just getting standards out there and making those standards more available should improve the ability to normalize this. But those standards have to be an aggregate. We have to talk about that together around what is standard of care. Our CMS needs to work on ways to improve the variability. How do we think about, and I'm not going to use Availity as the only aggregator out there. The CMS and others are focused on the idea of a QHIN. So the idea of a quality health information network, HIEs used to be that. So there is this focus to create platforms that are aggregators, right? Availity has about 70% of all healthcare transactions going through it. We have a multi-payer portal. So we're big believers on having a platform that sits on both sides of the equation with a, what I would say, Switzerland approach. We don't have a dog in the fight. Well, what our dog in the fight is, we want to make sure that it is improved, measurably improved across the board. So my argument to the industry is we have to at least take advantage of the aggregators to move these things forward. If you have a standard that's a Da Vinci standard and that provider is not ready to submit a FHIR-based API, or they're in the middle of a consolidation with 3 other systems out there, and you got to wait for that to happen before your interoperability, you're not going to get there. So the idea is that you move into where the provider is ready or the payer is ready, and using aggregators to meaningfully move it forward is what we would suggest as one of the solutions. And again, as Availity, that's one of our value propositions. We do want to promote standards. We're part of the working groups. I think just as an industry, I haven't seen the level of collaboration to date, at least in this problem. And I think it's getting some teeth. So I would continue to focus on participating in those standards as a way to have your voice. And I know all the payer investor partners that we have are participating in that. Not all of this, there's no easy answer. A payer who says, I'm going to do a gold carding or other regulation is also going to have to eat that medical cost if it doesn't go well. So making sure there's honest and transparent conversations is a key to that. So one of the things that the approach we've taken at Availity is not, and we have a rev cycle management platform that does do point to point, and most of those are Epic providers. We're rev cycle, so I'm not discounting the need to have, especially at an organization, solutions go point to point. But even 3,500 systems that are underneath our rev cycle management aren't scratching the surface of volume. So we create sort of a one set of APIs that can be purported into a number of different channels. So the first one, Epic's definitely pushing for, and I know Judy's here, their Epic Payer Portal is a point-to-point solution in the market where the provider can submit, if they have an Epic instance, to a payer who has an Epic instance in order to promote data interoperability. We like that. The problem with that is that if you're a provider who has an Epic instance, you have to connect to all of the payers that have Epic instances, and you get these sort of point-to-point solutions. So what we do at Availity is we sort of become that wrapper. We're the payer front door. Provider signs up with a payer portal. We become sort of the catcher's mitt on that one, and we route it effectively to the payer. So we sort of operate as a wrapper on top of that, or other types of sort of point-to-point solutions as they go through. We're the aggregator of providers and payers, and so where the multi-payer can go to an Availity, multi-provider can go to Availity, and then we're also the trading partner aggregator. So as we find trading partners who have signed up and can meaningfully deliver APIs, especially clinical data, we prefer those trading partners. And we work with those trading partners, even on a financial model, to make sure that we get good incentive in the market. As that increases, we'll find trading partners who have specialization in certain areas. And this is where I would suggest, if we can solve authorization, I usually say it's the Trojan horse for clinical data acquisition. It's the one area that everyone wants to solve badly enough in order to be connected. If you look at gaps in care or everything else, sometimes it matters to the CFO or to Pop Health. It's not enough where the entire payer system gets benefits and the provider system gets benefits. So the reason I'm suggesting, don't just go, if you're a payer or provider out there, go and ask for solutions that are broad enough in the market where not only does it meaningfully improve this, but you can then use those connections for other types of use cases, right? So that's why I like authorization. You can ask for clinical documents and get clinical documents. There are very other systems out there to do that. And lastly, and should be by exception. So if you look in, Availity's history, it started with the financial data, and then there was a payer portal. You still need a payer portal. We're still getting people signing up for payer portal for claim submissions, right? And it's these sort of by exception, mom and pop type of a scenario. We need a portal. We need a multi-payer portal. But my suggestion is that we do API first as our measurement success, portal last, and we'll still have to have that portal, but fax and phone should go the wayside. But we do want to make sure that the portal exists as a sort of omni-channel. So takeaways, first of all, build on the investments. The industry's made a pretty significant amount of investments in this area. It just hasn't demonstrated significant results. Portals are an example of that. Configure your portal with others instead of the payer doing their portal each one. That's kind of gone by the wayside. Same thing for APIs. And so the goal here is that we as an aggregator, other industry solutions, build on those investments, move forward, but let's set some better standards on success criteria. Auth is a use case. One, again, it's one of those areas that we just came with from our Connects conference, which is 137 payers with 60 some providers. And this was the most talked about use case out there across the board. Let's solve authorizations and then use that process to optimize AI solutions and others. Let's integrate into clinical data on top of that use case. So that's my interoperability and authorization use case. Please, if you've got time tomorrow at 9:30 to see how this is operating and working, we've got industry partner solutions next door at 9:30. We got about 5 minutes for questions. So the question was, Availity's acquisition of Olive's Auth AI, how's it working out? I would ask my Florida team here. They are across the state of Florida, commercial, Medicare Advantage, advanced imaging, hip and knee and musculoskeletal were brought in from Magellan's AI solution in 2022. We are seeing a significant benefit of being on Availity's platform. I came over from that acquisition as well. So we're seeing a significant benefit on Availity's platform, just customer platform. We can go in and say, look, let's scale this solution out and not just like we were a startup going to a point solution and proving that we were going to be around. Oh, by the way, Olive's not around, as a scenario. So I think being on an industry platform with customers and trusted customers, that's been fantastic, the collaboration across the board. AI, the use of AI to answer this question meaningfully, it works. And so what we do is we present the attestation tree. We build that attestation tree from the medical policy, right? So we're creating transparency. You build the case. We have the drag and drop or through APIs. We get clinical data, and we tell the end user what we were looking for and what we found. So it creates a really nice transparency and trust to the provider as compared to black box. And then we make recommendations as often as the nurses used to at NAA. So I think it's a great use case. I think it will scale meaningfully. Our team then Availity's not been just doing authorization for the last, year and a half. So they've been a multi-payer of choice for a number of years. Our API connectivity has been something we've been leading with. We're on the Da Vinci working group, so forth. We've now consolidated the end-to-end authorization under this team. And so we're seeing some of the benefits of the technology advances we have at scale now for how do I submit a case? How's our portal submission? All of that stuff's being integrated. So again, a little bit selfish, but it's been a great partnership.